This is about some weird things that antibiotics can apparently do. And emergency doctors are pain pill antibiotic doctors. That's what we are. We're the pain pill antibiotic doctors. And some of these things are kind of curious, like the studies that say erythromycin and all the family of erythromycin, azithromycin, clarithromycin, all that stuff, in some people will kill you. This is a first paper, is a study of the association of sudden death and concomitant use of erythromycin. And it concluded that you're twice as likely to die of sudden death if you're under the influence of erythromycin. And that is not a fluke, that we have other papers that basically show that as well. This paper also suggested that if you're taking other drugs that inhibit your P450 pathway in the liver, that kind of thing, that and they give a couple of lists in that abstract. They talk about azole, antifungals, diltiazem, verapamil. Aren't they heart drugs? That your risk of sudden death is 5 times greater when you are under the influence of those drugs, taking erythromycin. It also showed in the same paper that we're reviewing here the relationship between taking these drugs and digoxin toxicity. Now, you don't see people taking digoxin anymore, I guess, fortunately. Within 1 week of starting erythromycin, the incidence of admissions for dig toxicity odds ratio went up 12-fold. 12-fold when this relationship. Within 3 weeks of taking starting erythromycin, being on digoxin, the likelihood of you being admitted for dig toxicity went up 8.5-fold. So that these drugs basically affect the effect of other drugs, and they also do independently some nasty things in terms of sudden death. So they conclude maybe we should be a little bit careful. You have maybe somebody coming in who's got one of these implantable defibrillator jobs, who is maybe prone to some arrhythmia kind of thing, and they have a little bronchitis. Well, here, have some Z-Pak for you kind of thing. Maybe another choice may be appropriate, although there is no data specifically saying that that's a bad thing to do. It is just speculated that in people who are prone to arrhythmias, like congestive heart failure people are prone to sudden death, that maybe you're not exactly doing them a favor when you give them that Z-Pak, and maybe you should consider maybe something else and nobody will ever know you did it. But it's one of those things where there's some speculated risk here. Now, this other thing about the influence of, there's another paper that's toward the back here, but I wanted to catch it at this time, where they talked about erythromycin and the risk of sudden death. Actually, it's a brand new paper. It is not in your database yet. It was just put in the abstracts this month. It showed, in a large database review, almost a 3-fold increase in the incidence of sudden death in people who are taking erythromycin or any of its cousins. That paper also showed that there's a 5-fold increase in sudden death if you were taking antipsychotic drugs, like Haldol, Doperidol, and at the top of the list it was that older drug people used called thioridazine, which was Mellaril, but Haldol, chlorpromazine, thioridazine, 5-fold increase if you were taking one of those, and because they're all QT prolongers, and poor old droperidol gets sucked out, it said, saying, this is the one we got a problem with, when in fact it was no worse than any of the others, and maybe better than some. The second paper there is about fluoroquinolones causing tossades. They basically said this is a QT prolongator, and if you give it to people who are prone to arrhythmias, maybe there is a problem. They suggested that those were other QT prolonging drugs, people who had left ventricular dysfunction. Those are congestive heart failure patients who have a likelihood of dying sudden death. As a matter of fact, once a diagnosis of congestive heart failure is made in a person, if you had the choice of making having cancer or CHF, you should choose cancer. You will live longer with a diagnosis of cancer on average than you will once a diagnosis of CHF is made in terms of the 5-year mortality of those cases. They also said that patients who have low K, low MAG would be patients who could be concerned that fluoroquinolones may be a precipitant of some of these potential problems with arrhythmias, which are really quite not a lot of people know about this relationship. papers 3 and 4 talk about fluoroquinolone tendinopathies. And there's no question that there's an increased risk of rupturing your tendon. The tendon that is at the top of the list by far is the Achilles tendon. This is generally a problem associated with older people, 60 and above. It is a problem that is related. We know about this cartilage problem and fluoroquinolones, and that's why it wasn't given to the little kids. Well, this is another kind of problem that's involved in this large database that they look at this stuff. The odds ratio for a tendon rupture was about 2.5 on people who are on fluoroquinolones. And the fact is that they think that there may be some theoretical risk, and maybe you'll make it worse if these people are also on steroids, which is known to increase tendon problems. That maybe that you ought to consider those cases. I don't know. There's they also suggest that it's dose dependent. The more you give, they point out that if you're giving the usual doses of fluoroquinolones, your risk goes up to 6.7 times greater. If you give higher doses, your risk of a tendon rupture is 12 times greater. The risk is related to your age. The older you are, if you're between the ages of 60 and 79, the risk is about 6 times greater. If you're over the age of 79, your risk is 20 times greater that you will rupture your Achilles tendon in this process. All fluoroquinolones are not alike. Look at the difference here in this paper. I guess this is number 3. Cipro is the best, 3.5 times greater risk of rupture. Ofloxacin is the worst, 28 times greater risk of rupture. So that it's not although it may be a class effect for all of the fluoroquinolones, some are much worse than others in causing this potential problem. 4 is a review of 98 cases. 90% of them were Achilles, mostly men. 40% were ruptured. They said there were predisposing factors. There was a list of them. Decreased renal function, rheumatic disease, diabetes, hypothyroid, playing sports, and hyperparathyroidism. They had patients under the age of 60. That other study, nobody was under the age of 60. The lowest age person was 28 years old in this review of 98 cases. Will that affect who gets fluoroquinolones? Probably not, but I guess we should probably be aware of it. It's not the same as sudden death, which is the risk is a little higher. This next paper, I think, is really a fascinating paper. This is the one about antibiotics and warfarin. Lots of people are on warfarin. They're going to try to prevent urine atrial fibrillation. We're going to give you a warfarin to prevent your stroke kind of thing. Look what happened to the INRs within 1 week of starting azithromycin, levaquin, or trimethoprim sulfamethoxazole, otherwise known as Bactrim. The INRs went up. These are people, 75 people, over the ages 70. They had all stable INRs. They started them on these antibiotics, and they serially measured their INR for a week. Azithromycin, basically the level INR went up 0.5. Levaquin went up 0.8. Trimethoprim sulfamethoxazole went up 1.8. So it took them outside of the range of normal. The people taking azithromycin, a third of them were above the range of therapeutic. 39% of the Levaquin people were outside the range of therapeutic. 69% of the people on Bactrim were outside the range of therapeutic. The INRs being over 4, with azithromycin 16%, with Levaquin 19%, with trimethoprim sulfamethoxazole 44% of the people had INRs over 4 within 1 week of starting those antibiotics. So trimethoprim sulfamethoxazole, Bactrim, seems to be the bad guy here. When they looked at that subset in particular, 38% had a mean INR increase of 2. A third of them had an INR over 5. A third of them had an INR over 5, and 13% of them bled. This relationship sounds pretty substantial, clinically significant, and something that I was personally totally unaware of. That's abstract number 5. So, we all see people whose INRs are high, and the family doctor, they don't know why it went up. They're on the same medicine all the time now. Why would we get it? Well, maybe this would be a reason. Oh, well, we got put on, there was some urinary infection or something like that. Here's your Bactrim kind of thing. And this thing seems to drive these INRs substantially outside of the clinical range to the point that some of them had bleeding, 1 in 8. Now, I don't know. It seems to me that we have to have more studies on this because these numbers are really kind of frightening and compelling. 6 is a really fascinating thing about people given sulfonamides as an antibiotic when it acts as a sulfonylurea in diabetics. Is this weird or what? They sound the same? Well, they tend to act the same. So this is a paper, extensive Canadian database, looking at people over the age of 65 who were on sulfonylureas for diabetes, who were then given some sulfur drugs for their Bactrim. They got them Bactrim for their urine infection. And they looked at the incidence of drops in their blood sugar and the odds ratio for admission for low blood sugars in diabetics. Once they got on Bactrim, within 1 week, the odds ratio for admission for hypoglycemia was 6.5-fold greater. And within 2 weeks, it was about 6. Within 3 weeks, it was around 5 times greater. So these drugs were acting as sugar-lowering drugs, just like sulfonylureas did, and something that I think would probably be aware of, kind of thing, especially if they seem to be well controlled on their oral sulfonylureas, and here's your Bactrim kind of thing, and now your blood sugar is low for some reason. Well, this is the reason. I was totally unaware of this relationship. I was unaware of the previous relationship. I was unaware of this. I knew something about antibiotics and sudden death, but not to the magnitude that they're talking about. And by far, the most thing I knew about this stuff is that psychotropic drugs were associated with sudden death. There's no question that schizophrenics had more sudden deaths than not, probably related to these medicines. And then the last thing here is about antibiotics and birth control pills. How many of you talk to your patients when you give them an antibiotic about this might screw up and make your birth controls less effective as a routine? Because, you know, I was clueless to this, totally clueless. Let's just see the hands. We'll have a little study we'll publish. Okay, so I'd say it was the minority, but it's about 30%. 1 in 3 of you say something to patients because if you read the 2006 PDR for a low overall 28, it says that you should advise patients who are on, and they list a number of antibiotics, amoxicillin, penicillin, tetracycline. So which ones specifically, we don't know yet. I'll get to that in a bit. But they say these women who are on these things should be on barrier-type contraception while they're on these antibiotics and stay on it for a week there until they stop. So they asked in paper number 7, do British doctors know this? And did they ever document that they've told any women about this? Because this paper, number 7, says a U.S. dentist was successfully sued for the pregnancy in one of his patients as a result of not advising them about this, which is kind of scary to me, if you ask me that, because we give out antibiotics right and left kind of thing. But it would be interesting to ask Greg whether he's ever heard of a case of a doctor being successfully sued because of a pregnancy that occurred under this theory here. But in any case, these British doctors were pretty clueless to this relationship, and they rarely wrote any documentation. I think it was only 2 of 21 patients got documented advice regarding non-hormonal contraceptives. Only 5 of 12 physicians knew about this issue. And in the United States, where we're kind of sue crazy kind of thing, you can see that there's not a standard of care here. 1/3 of your colleagues do this, and the other 2/3 don't do this. And I've asked this question at other courses, and it's surprising the fact that, because I never did, because I wasn't aware of this, so I never did this, but I was aware of, oh, geez, look at all the other doctors who do this. I better get with the program. Number 8 says, however, you don't really need to get with the program. Number 8 is a more careful look at whether, in fact, there is truly a decrease in the effectiveness of birth control pills under the influence of antibiotics. And they think, based on their analysis, that the answer is there's only one antibiotic that is associated with a decrease in the use of antibiotics, and that's rifampin. But yet, there's more and more rifampin going to be given out because there's more and more of this staph thing here that we're treating now, this MRA-resistant staph. So we're giving out this rifampin, going to be right and left. And if you are going to do that, you better, because the literature is not going to help you here. They're going to nail you if, in fact, somebody gets pregnant because you didn't tell me, doctor. So rifampin was hardly ever used by emergency physicians in the past. Meningococcemia exposure, fine, here's take it a couple of these for a few days kind of thing. That was it. Now, there's going to be a lot more use of rifampin, and in fact, in many cases, it will be the drug of choice for all these boils that come in that look a little purplish compared to the others that you're used to seeing, and rifampin is going to be like water given out in the emergency departments. So perhaps you should know this, but they say, with all the other antibiotics, the Keflex and that, they can't really find a relationship. So for those of us who never did it, we like paper number 7 for number 8. For those of you who do it all the time, you should like paper number 7. So that's a word to the wise, perhaps. I want to thank you for attending. You get your certificates. Please make sure that you fill out your evaluation forms. We appreciate you doing that. If you do want a CD of the manual, ema@emaonline.org. We'll be happy to send you one, and we look forward to seeing you in the future. Thank you.